Good morning and welcome to another webinar hosted by PAHO and PANCAP. My name is Sandra Jones, advisor with the Pan American Health Organization Sub-Regional Office in Barbados. I will be your host for today. Today's webinar, Access to COVID-19 Vaccines, and which will also look at the COVAX mechanisms, which are aimed to ensure that everyone in the world have access to vaccine in a timely manner, are the two topics for today. Over the past few weeks, we have all heard of the numerous advances with the COVID vaccines that are becoming global, that are becoming global realities. Yesterday, the world watched as the UK commenced vaccination for COVID-19 to its citizens. Today, we have two experts who will be making presentations followed by your questions, comments, and reactions to the areas discussed. Before we get into the presentations and some housekeeping, on the screens, there are two poll questions, and which we are asking your kind support to proceed to answer the questions that are posted. Thank you in advance for taking the poll. Just a gentle reminder in terms of the housekeeping announcements. Your mics are muted, and you can feel free to type any questions, comments, or clarification you may have in the section provided. At the end of the presentations, we are going to be opening up for questions and answers, and we will be addressing the questions accordingly. Do we have the two polls completed? Is it poll one?
Yeah. You can continue.
Okay, thank you. As I said earlier, thank you very much for taking the time to participate in the poll. Our presenters for today are Dr. Beryl Irons and Dr. Karen Broom. Our first presenter will be Dr. Irons, who is a pediatrician and public health consultant who retired from PAHO after serving approximately 20 years of service to the Caribbean, which among others include expanded program on the expanded program on immunization as one of her area of focus. Dr. Karen Broom is our second presenter. She is a physician and public health practitioner who has worked in the Ministry of Health Barbados for over 21 years and serves as the Senior Medical Officer of Health responsible for the National Expanded Program on Immunization, Maternal and Child Health, among other areas. Dr. Broom is currently a short-term sub-regional advisor for immunization with the Pan American Health Organization sub-regional office in the Caribbean based in Barbados. Within this capacity and during the pandemic, Dr. Broom has assisted countries in the region to strengthen national immunization programs, as well as the introduction and deployment of COVID-19 vaccine. Please join me in welcoming my two colleagues, Dr. Beryl Irons and Dr. Karen Broom, for presenting for accepting first the invitation and for being the presenters for today. So right now, without any hesitation, I will turn over to Dr. Irons, who will start the presentation. Dr. Irons, over to you, please.
Thank you very much, Sandra. It's our pleasure at this time to be involved in this webinar, and we would like to thank the organization and the two organizations and organizers, PAHO, Pan American Health Organization, and PANCAP for this invitation. And we also hope that during these presentations that there will be more enlightened and it will be very positive on viewing. At this time, I would also like to declare the declaration of interest. I'm a member of the PAHO Regional Certification Commission on Polio Endgame in the Americas, also a member of the Caribbean Immunization Technical Advisory Group. I have no financial interest in vaccines. And I would also like to acknowledge the material receipt and also information from Professor Peter Figueroa and Dr. Karen Lewis Bell. Next slide, please. Next slide, please. Next slide, please. All right, during this presentation, we will be discussing, one, the definition of immunization. We'll be taking a step in the past to look at the Caribbean achievements in immunization. And it's extremely important because through mass vaccination, the Caribbean and the rest of the world were able to eliminate many diseases, vaccine preventable diseases. So we're going to just take a look in the past, and then we will move to the pandemic and vaccine development, the COVID-19 vaccine candidates, the COVAX mechanisms, and those will be presented by Dr. Karen Broom-Toppin, and then we end with challenges and conclusion. Next, please. Immunization, one of the most important public health success in history, has resulted in significant decreases in many diseases. And as you know, the purpose of immunization is to induce protection from subsequent disease with the use of vaccines. So once you have been vaccinated, you would have developed immunity, and then you would be protected. Vaccines are complex biological products which are designed to induce a protective immune response effectively and safely. And I want to emphasize the aspect of safety, which is the most important thing. Therefore, vaccines train the immune system to recognize the pathogen when it is encountered naturally. And immunity following vaccination lasts for months to years, depending on the type of vaccine as well as host factors. And I want to remind us that every day we are being vaccinated naturally. Once we are exposed to any bacteria, any virus, the body naturally would mount its own immune response and develop antibodies. Next, please. Now, when most persons in a community are vaccinated against a disease, the ability of the pathogen to spread is quite limited, because once you have developed immunity and you're exposed, you would not come down with the disease. And it's on this premise that the phrase herd immunity is coined. When many persons have immunity, this also indirectly protects others who cannot be vaccinated, such as very young babies and those who have compromised immune systems. Next, please. Now, if we step back in the past, we know, which is also the present, that the Caribbean has led the world with immunization. And it was the first sub-region in the world to achieve elimination of polio, measles, rubella, and congenital rubella syndrome. And what was very good, it was national funding, almost 100%. So the funding was found by the governments of the country. If we look at some of the diseases that we really don't see anymore, yellow fever, last indigenous case was in 1978. Although you might see importation, they have not from endemic cases. Poliomyelitis was in Jamaica last case, 1982. The yellow fever was in Trinidad and Tobago. Measles, 1991 for the entire countries of the Caribbean community. Congenital rubella syndrome, 1999 for that community also. We have diphtheria in 1994, neonatal tetanus in 2000, and rubella in 2002. And I've chosen those diseases because those diseases, the elimination was on the fact of adults being vaccinated in most of these cases. And here we can see poliomyelitis. And these are images that we have not seen for decades. All right, next please. Neonatal tetanus and tetanus. I am sure I can tell you that most physicians have never seen cases. And measles, 1991, we have not seen any endemic case. Next one, please. Congenital rubella syndrome. And when you think of that, with the babies we were born with microcephaly, heart disease, the babies would also have cataracts, microphthalmia, and several other conditions. Vaccination is the reason, immunization, that we do not see these diseases. Next, please. Now, the Caribbean has been remarkably successful in preventing the reintroduction of measles virus into the countries. And this success has come despite 40 million persons visiting the Caribbean, and many coming from areas such as Europe and Africa, where the virus continues to circulate. And that although there has been importation in some countries like Trinidad and Tobago, in Jamaica, in Bahamas, we have not had endemic cases. The reason being, we have a well-vaccinated population in the country. Next. All right, this is one of our classic slides. And the classic slide shows, can we go back, show that you can see from 1980 where you're seeing the diseases, over 10,000 cases, etc. And then you see the vaccination. So as the vaccination coverage increases, the diseases decreases. And so it's classic for Jamaica, for Barbados, for Trinidad and Tobago, for Guyana, for all the countries of the Caribbean. They have worked successfully for these eliminations. Next one, please. So the reason for this success is concerted effort of governments, and of which CARICOM, the Caribbean community, played vital roles. Commitment of healthcare professionals and the population, and technical expertise and guidance from our agency, Pan American Health Organization and World Health, which resulted in the elimination of the diseases. And as I said before, and I want to repeat, well-vaccinated population in countries. So in essence, I'm sure that all the persons on this webinar also need to be congratulated, because they have also played role in the continuous elimination. Now, why are we discussing vaccine preventable disease in the midst of COVID-19 pandemic? Next. If we look at the COVID-19 pandemic, it has transformed the year 2020. We have had more than 65 million confirmed cases globally, over 1.5 million deaths. It has crippled our economies, and especially being small island states, and most of our economy contribution to our GDP coming from tourism, most of our countries are crippled. And it has also disrupted social life. And I guess I won't have to comment on that. Next, please. Now, COVID-19 is now a vaccine preventable disease. And the commitment, dedication, and strategies used for the elimination of other diseases will have to be utilized to decrease the number of cases with the ensuing morbidity and mortality. And so in moving to the future, the present and future, we have to learn from the past. Now, what are the actions taken to develop a vaccine to ensure that it is safe and it works well? Now, there are many phases, approximately 5 phases. Now, the first is the preclinical studies. In general, vaccine is tested in animal studies for efficacy and safety. And then after preclinical studies, one moves to phase 1 clinical trial, where you have small groups of healthy adult volunteers who would receive the vaccine to test for safety. So the vaccine is then given to the volunteers, and one sees what happens next. Then, with the vaccine being proclaimed to be safe, one moves to phase 2 clinical trial. Here, the vaccine is given to people who have characteristics such as age and physical health, similar to those for whom the new vaccine is intended. And so, for example, if we look at the COVID-19 vaccine, it means that this vaccine will be given to persons who are of the older population, young, mid, old population, persons with comorbidities, because these are the persons who are affected mostly by the disease. Then there is a phase 3 clinical trial where the vaccine is given to thousands of people and tested for efficacy and safety. And then we have the phase 4 post-marketing surveillance. After the vaccine is approved and licensed, the vaccine is given to persons who need it. Then the population is monitored, especially those who have been vaccinated. They are monitored for adverse events and also to study the long-term effects of the vaccine in the population. And now you'll have Dr. Broom.
Good afternoon, everyone, and thank you very much for allowing me to be here this afternoon to speak to you on COVAX mechanism and access to COVID-19 vaccine. So the COVAX facility is a collaboration between PAHO WHO, Gavi, the Vaccine Alliance, and CEPI, the Coalition for Epidemic Preparedness Innovations. And it is a way for countries to pool purchasing power to invest in a broad portfolio of vaccine candidates. It is important that the portfolio is diverse and that it has different technologies and that the vaccines have different characteristics. The goal of the COVAX facility really is to deliver 2 billion doses by the end of 2021, and not only to deliver, but to guarantee fair and equitable access. We're going to speak later on about 3 of the candidate vaccines that we have seen in the media and have released their efficacy data. And 2 of those vaccines are currently in the portfolio, and there are others that are being considered. So the candidates, as we're going to see later on, are assessed on several different dimensions, and that includes, of course, safety, efficacy, and the ability of the manufacturer to supply the vaccine. And countries can access the COVAX portfolio through the PAHO revolving fund. There are 3 possible modalities for how countries can gain access to COVID-19 vaccine. The first one is by a national access mechanism. So the country goes on its own to manufacturers and negotiates price and logistics. And we have seen examples of that with the US and Canada and the UK. The second possible modality is through a group access mechanism where countries form regional groups and they go to the manufacturers as a block, and they then hammer out supply agreements. And we saw this with the European Union. The last possible modality is via a global access mechanism. And this is what the COVAX facility is, where countries participate in a global mechanism to access the products. Now, this access must provide equity and fair allocation through all countries, and that is what they aim to provide. If we have many countries pooling their financial resources, then we have less risk for other countries, for everyone. So it is more of a risk for one country to go to each manufacturer, because then you only have one or two vaccines that you have access to. And whereas in a pooled facility, the countries have several vaccines that they can have access to, and hence through several manufacturers. Next slide. So the COVAX facility focuses on transparency and global access. So countries who are part of the facility pool their demand, and through the COVAX facility, they then have access to manufacturers, because the COVAX facility goes then with a great purchasing power to then negotiate with manufacturers and have a wide variety of vaccines and products available to them. Next slide. So participants have the option of either the committed purchase model or the optional purchase model. If you are a self-financing country, we will talk about the other AMC countries shortly. If you are a self-financing country, if you choose the committed purchase model, you have a lower down payment to make, but you have to provide a financial guarantee that you will be able to purchase the doses that you have ordered. Countries that have chosen the optional purchase model, they have a higher upfront payment, but they have the option to decide on what doses they're purchasing, but they must also provide a small risk-sharing guarantee. Next slide. So I spoke before about COVAX AMC members. And what AMC really means is just advanced market countries. And these are low and middle income countries that the COVAX facility will assist in purchasing vaccines. In the Caribbean, these countries are Dominica, Grenada, Guyana, St. Lucia, St. Vincent and the Grenadines, and Haiti. Next slide. So not only is there support in terms of vaccine access and financial support for vaccine procurement for the AMC 92 countries, but there's also support through UNICEF and PAHO. And this involves some technical assistance in getting their vaccine plans and logistics and cold chain sorted, and also again in delivery. So they will have support for the cold chain equipment and again technical assistance. It's important to note that all options explored will aim to ensure that participants do not face any significant barriers to access a COVID-19 vaccine. Next slide. So the two main goals of the vaccination program are significantly linked. One is to improve individual and public health, and two, minimize societal and economic impact. All of us know that health is not just about physical wellness, but about mental well-being and about society. We all know about the determinants of health. And if we didn't know, we surely knew by what we all experienced this year in terms of how we had to manage and control the COVID-19 epidemic and pandemic. We have to significantly reduce the impacts of COVID-19 in the safest, quickest, and most effective way. And this can be done by a successful vaccination program. Next. So how do we allocate these COVID-19 vaccines? What sort of mechanism do we have? We spoke about the goal, which is to protect public health and reduce COVID-19 mortality. But there must be priority cohorts or priority populations to receive the vaccine. And the recommendations are that healthcare workers are the first to receive, and these recommendations were made using guidelines from SAGE, which is a strategic advisory group of experts, and they offer advice and guidance to WHO. And it is recommended that the first 3% of the population, which is the healthcare workers, get the vaccine first. And this then will be followed by the high-risk adults, which would be the remaining 20% of allocation. But of course, this allocation would be received in tranches, because allocation all depends on how the vaccine manufacturers or how fast they can get their doses manufactured, and therefore the logistics of getting the tranches to the countries. So after the 20% of the population is immunized, that is the 3% that has to do with the healthcare workers, and then the remainder, the high-risk adults, further priority groups can be decided on by the countries. And let me make it clear that these are just recommendations, that the country has the ability to decide on what their priority groups would be for vaccination, depending on their facility and what's happening on the ground. Next slide. So as I said, WHO SAGE has developed some documents, and they also endorse the values framework, which guides countries on how they could allocate and prioritize COVID-19 vaccination. It looks at the principles and the objectives and target groups of a COVID-19 vaccination program, and this was published in September of this year. We also saw the WHO SAGE roadmap for prioritizing uses of the COVID-19 vaccine, and that was published in November the 13th. And that looked at the how can we prioritize the use of COVID-19 in the context of a limited supply, or in the context of different epidemiological settings, because not every country is the same. Some countries have numerous cases of COVID-19 to manage. Some countries have outbreaks in certain districts and areas, and other countries do not. So this roadmap really looked at how, in different settings, we can prioritize how the vaccine is used. The next set of recommendations we look forward to once we have a COVID-19 vaccine registered. Once there's regulatory approval for the vaccine, then we're going to look at the consideration of the vaccine, look at specific data and attributes, and discuss how the vaccine should be prioritized based on the specific attributes of that vaccine. So we saw this already with Dr. Aaron's presentation on the steps in vaccine development. Next slide. And this is the current COVID-19 landscape as of November the 12th, where we had 164 in preclinical evaluation, 27 in phase 1 and 50 in phase 1 and 2, and we heard that those were where we looked at a small number of persons in trials, and then we have 10 in phase 3, which is a large number, tens of thousands of persons being in trials, and we have one vaccine so far being approved by the UK. Next slide. So there are many different types of COVID-19 candidate vaccines being developed, and they are developed using different platforms. And we're not going to go into the intricacies of the platforms, but just to say that there are live attenuated virus vaccines and inactivated virus vaccines, vaccines that are nucleic acid vaccines, viral vector vaccines, and protein-based vaccines. Next slide. So you hear a lot about the fast tracking of COVID-19 vaccines, but the truth is that there have been efforts to develop a vaccine against the common cold, and you know the common cold is caused by coronaviruses, and these have been ongoing for decades. In 2005, we saw the SARS outbreak, and that also simulated research for the vaccine against the spike protein of the SARS virus. And in 2012, many of us know about the MERS outbreak. That again was a coronavirus and stimulated further research. So by the time we got to January 2019 and the genome of the SARS-CoV-2 was decoded, we were able to begin research to prepare a vaccine immediately because of the work that has been ongoing for years and years before. And we know that we have highly sophisticated technology available now that we didn't have when some of the earlier vaccines were being developed. So we know, we've all seen in the media that thousands of people have been included in the vaccine trials, and that includes men, women, diverse races and cultures, and different ages of persons. We see that some trials had over 30,000, others 40,000, and in China and Russia, they had over 100,000 persons each being vaccinated. And the information that is coming out on the trials has been very, very encouraging. And this is just a slide showing the ongoing clinical trials of the COVID-19 vaccine candidates and which countries in the world and how many trials have been in different countries. Next slide. So this is a very busy slide, and what I really want you to take from this, these are the, as of November 16th, because things change, these are the candidate vaccines in phase 3 at this point. We can see here the ones that we have gotten information on. AstraZeneca, that's the one at the top, and we can see also the Moderna, we've heard a lot about that, and the Pfizer that is right below it. Next slide. So it is important that we have a pool of vaccines because one, we don't know if a vaccine will be successful, and two, no one manufacturer has the ability to manufacture enough vaccine for the whole world. So the world has to be covered by several vaccines. So a diverse portfolio, which is one that the COVAX facility has developed and is managing, is important to diversify risk and create capacity. Next slide. So yes, the COVAX facility has selected a basket of vaccine candidates, and they continue to negotiate with manufacturers so that they have enough doses, and if some vaccines don't quite make it, then there are still other vaccines that have a chance to be successful and will therefore be able to be used in country. So this slide just shows you the COVID-19 vaccine portfolio held by CEPI for the COVAX facility. And you can see here that there are 9 and that there are 8 in clinical trials and 2 in phase 3. And we know those 2, AstraZeneca and the Moderna, they're in phase 2. And here we have those vaccines that the Bill and Melinda Gates Foundation has been looking at in collaboration with CEPI for inclusion into the COVAX facility. So it is not just about getting a group of vaccines and that is the end all and be all. We have to keep looking to see what other vaccines are in the pipeline and what would be the best for the countries. And it is looking at the vaccines in terms of the manufacturer's existing capacity. Do they have the capacity to manufacture the amount of doses that would be required? What about the goods that are being used to manufacture the vaccines? Are they expensive? What are the cost of these goods? And what is the expected potency, the efficacy of these vaccines? So if we take a closer look at the 3 COVID-19 vaccines candidates that we've heard a lot about in the news, in the media, because they have released efficacy data, and they have actually started the process of looking for emergency approval. In terms of the efficacy, we see that the Pfizer and Moderna have around a 95% efficacy, with the AstraZeneca coming in at 70%. And this is because the AstraZeneca had a 90% efficacy with a small group of participants that received half a dose for the first dose and then a full dose for the second dose. And that efficacy came out at 90%, whereas those who received the 2 full doses, they had an efficacy of 62%. We've heard a lot about can we go back to the other slide? Thank you. We've heard a lot about the fact that Moderna and Pfizer are mRNA vaccines, and they use that platform, and the AstraZeneca is an adenovirus vector. A lot of conversation has gone on around the fact that the Pfizer vaccine has to be stored at an ultra cold temperature, and that the Moderna has to be frozen. But if we look at the shelf life, we see that 5 days, that 2 to 8 degrees for 5 days for the Pfizer, and that the Moderna can be stored at room temperature for 12 hours, and the AstraZeneca 2 to 8 degrees Celsius for 2 months. And we see some approximate cost per dose. And of course, this all has to do with the purchasing power of the manufacturers, the countries or the facilities that go to the manufacturers to purchase vaccines. So this is just what has been postulated for the pricing, but pricing will differ. The administration routes, we see most of these vaccines are 2 doses and by intramuscular route. And there has been emergency authorization given for the UK for the Pfizer, and the Pfizer and Moderna both apply to the FDA for authorization. And the AstraZeneca said they will seek emergency authorization from WHO. Important again is the capacity of the manufacturers to produce. And we see that the Pfizer and the AstraZeneca can produce over 1 billion doses for next year. And the Moderna has estimated that they should be able to produce 500 million to 1 billion in 2021. Next slide. So it's a lot about the vaccine and the COVAX facility and the access. But without a good structure in place in country, we will not be able to get the vaccine to persons who need it on the ground. And the guidance is that, and what countries are working on, is the National Coordinating Committee, which is the overarching committee, which is assisted by the Immunization Technical Advisory Group, and in the Caribbean, it is the Caribbean Technical Advisory Group on Immunization, the CITAG. And then this group has technical working committees that report to the NCC. And these technical working committees work on various areas of the vaccine planning and coordination and introduction and deployment. And we must have a similar structure going down regionally in the district and at the local level to make sure that the coordination happens from the top to the bottom to enable vaccine to be deployed successfully. Next slide. And here we see the areas that the countries are working on with their national deployment and vaccination plans for the COVID-19 vaccine. And PAHO has been really assisting countries to complete their plans or have them near finished by the end of the year, so that and completion also includes budgeting, so that we can look and see where countries may need assistance with getting their plans completed, so that the deployment and introduction can be successful. And here I will hand you back over to Dr. Aarons.
All right, thank you very much, Dr. Broom. At this section, we'll be looking at vaccine acceptance and what we consider will be some of the challenges. Next slide, please. Now, the perceptions of the public and the medical community about the disease, and in this case about COVID-19 and the vaccine, are important factors in determining acceptance of vaccination and the priority that will be given to it. In most countries globally, the acceptance of vaccination is the norm in majority of the populations. However, we do know that there is a small number who refuse some vaccines, some will agree to take some and not others, and some persons delay vaccination in general. And we also know from research that adults rely on their healthcare providers to give recommendations of vaccination, because there is that trust between the patient and the healthcare professional. There are several general factors that have been identified that affect vaccine acceptance. And some of that include the lack of knowledge about the need for vaccine. Just in general, the work, what does vaccines do? Then there is misperceptions about the vaccines and the disease. And we know that there are quite a lot of anti-vaccines persons and groups that are around. But I would just say to you, read information for yourself. There are also those who fear side effects after vaccination. And there are also those who fear just the fact of receiving a needle to give vaccination. There is also at times lack of trust in the health system. But in the Caribbean, our track record has been excellent. Excellent, because I am sure many of the persons on this seminar have never seen a case of neonatal tetanus. You have never seen a case of diphtheria. You have never seen a case of measles. You have never seen a case of congenital rubella syndrome. You have never seen a case of poliomyelitis. And these are rare, and you have not seen them because of vaccination. And there is also sometimes a history of negative interactions that occur between health personnel and also patients. And so it is extremely important that we ensure that we have a very good cordial relationship between patient and also providers. And sometimes, which is quite few and rare, there may be inconsistent vaccine availability. Next slide, please. Now, many factors converge to create barriers to vaccination. Some of them are at the systemic level, such as access to healthcare services, and some are at the patient level, where I mentioned inadequate knowledge regarding the vaccine and the benefits of the vaccine. Also, studies have also suggested that you have vaccine hesitant individuals who hold various degrees of indecision about specific vaccines or vaccination in general. And this can significantly contribute to decrease in the uptake of vaccines, especially newly introduced vaccines. Next, please. Now, if you look at the area of vaccine hesitancy, you can categorize the reasons in three major areas. One, complacency. The perceived risk of diseases are low, and the vaccination is not deemed a necessary preventive action or priority at that time. And I can think of in some, for example, in the childhood area, where you would find that because they have not seen these diseases, they keep forgetting what they're vaccinating against. The confidence, which is trust in the effectiveness and safety of vaccines and the systems that delivers them, the reliability and competence of the health services and the health professionals. And I would like to endorse the fact that you have very competent health services in the Caribbean, competent health professionals, and you have no reasons most time for not feeling very safe about vaccines. And I want you to transfer some of these trust and confidence and competence to the whole aspect of COVID-19 vaccines. And then we can think of the other area of convenience. What about the physical availability? What about availability in time? Do I have to spend too much time at the health facility? Is it affordable? Is it accessible? And the information, your ability to understand both the health literacy and the language itself. Next slide, please. Now, what are some of these strategies to address these issues? Because these issues need to be addressed because it's the same compilation of things that will be transferred to the COVID-19 vaccination. Next slide. Next slide, please. Now, in preparing ourselves for COVID-19, it means that we must be very ready to engage community members in a meaningful manner. We need to make them feel very comfortable, that they can ask all their questions, and we have to discuss the issues. We have to get buy-in from community leaders, including those from faith-based organizations, because we have to reach our population. We have to work with the country communicators. We have to collaborate with partners at various levels of the community, nationally, and within organizations. Now, concerns and rumors need to be addressed regardless if they are considered to be trivial. And so this is an area where as health workers and also as general population, we also have to have the right messages to give. We have to devise an approach to appeal to audience. And Champions was used for MMR, mass vaccination in adults. And it was very successful, where one would identify persons within the community. Some of them would have had children with conditions like those many years ago, and that they are able to speak about it, speak about what happened when they delayed vaccination, speak about what happened when they refused, and also to encourage the population about getting the vaccine. The processes have to be participatory and multi-sectoral. And in everything that we do, we have to build trust. Trust between health providers and population, trust within the population, and trust with national government, between national government and the population. Next, please. We have to use as many modalities as possible in the communication channel. And we know that at this time, social media is a very, very good avenue. But at the same time, you have to know the audience and you have to know your target group. And there are some things that we know. Idioms. The newspaper lasts longer. The radio reaches more people. The television has more influence. And then we can use modernly the web. We can put up question and answers, and we also can use mythbusters on COVID-19 vaccines. We have to use multiple modalities, each targeted to different audiences. Next, please. So in conclusion, to be successful, the COVID-19 vaccination program should provide education and increase awareness to counter the misinformation and negative perception of the vaccine. Healthcare professionals and the population in general have to be champions of the program and willing to recommend the vaccine to the target population. Government and population support are crucial for success. One of the best communication is person to person, even more than healthcare worker to patient. Therefore, what are some of the take-home messages that we have? One, the effort to develop a vaccine against the coronaviruses has been ongoing for decades, with acceleration in 2005 and 2012. And therefore, having a vaccine being available so quickly is not quickly, because we have been doing it for decades. The modified RNA vaccines do not use live virus that causes COVID-19, and they do not interfere with DNA. And these modified RNA vaccines that are in the Pfizer and the Moderna vaccines, this methodology and mechanism is one that is being used in the health sector. It is used in the treatment of cancer where they target cancer cells. So it's not a new mechanism. It is a mechanism that is in use, but it is now new to being used for vaccine development. Clinical trials conducted in several countries had more than 30,000 participants of both sexes, diverse ethnicity, and different ages. And so with that, it can be extrapolated to all countries. The findings from the trials, the vaccines are safe and efficacious. We need to remember that we will have to live with COVID-19 for the foreseeable future. The vaccine is not expected to be a silver bullet. So we will still need the non-pharmaceutical measures, and we'll still need some of the measures that we have, all right, like the distancing, etc., and so on. Vaccine is available, but at the same time, we'll have to use some of those measures. And we have to realize that change is inevitable. We have to prepare for more change because the situation is quite dynamic. And at this time, I want to make a suggestion. Take the vaccine when you get a chance. I can assure you that I will be taking it. Thank you.
Thank you very much, Dr. Iron and Dr. Broom, for the very comprehensive and excellent presentation, which provided in-depth understanding on vaccine, and particularly the COVID vaccine, and which demonstrated the value of immunization on preventable diseases, and of course the impact vaccination had or have had in the region over the past couple of years. Thank you also for the detailed explanation on the COVID-19 vaccine and the COVAX facility. And I was very much, I looked at the take-home messages. The two take-home messages that really stood out for me that I picked up were that we will be living with COVID for the foreseeable future, and you are so right. And secondly, we must prepare for change as the situation is indeed dynamic. As we go now, as we open up, because I'm sure there may be lots of questions. Before we go to the questions, we have the poll that is back on the screen. I ask for your kind indulgence again, if you could just once again respond to these two poll questions. Thank you very much. Thank you. I also like Dr. Irons and Dr. Broom, the presentation, which actually highlighted, and I think very convincingly highlighted some of the concerns that individuals may have regarding the COVID vaccine. So with this now, I will open the floor for questions. I will, let me see, just let me know, Shanti, when we're done with the question, with the poll.
The poll is ongoing, Sandra. You can do the Q&A now.
Oh, it is ongoing. Okay, perfect. So we will come back to the poll questions. Oh, what did I do? We will come back to the poll questions just before we end this session today. The questions. So I'm looking at, we have a question, and it says, where is this flu vaccine being made? I'm not certain. We're talking, where is this vaccine being made? I'm not certain which vaccine is being referred to. That is one of the questions. And we have another question that says, interesting to note is the fact that CARICOM countries do not have a united front in the fight against this pandemic, which is evident in the clustered procurement in opposition to one significant and more beneficial order as a region. I don't know if Dr. Broom, you would want to take this. I can read the question over again for if it's not clear. And then there was a first one said, I would like, where is the vaccine being made? I'm not certain which of the different ones they were being referred to, but maybe that could be responded to in a general manner as well. Thanks.
Thank you, Sandra. Just to say that CARICOM and the Caribbean are well represented within COVAX. And not only that, but we do have a couple of the Caribbean countries sitting on a couple of the committees that are within the facility and making decisions on what happens. So the Caribbean might not be alone in a block and going forward that way, but they definitely do have influence over decisions made, and they're well represented within the COVAX facility.
Could I also make a comment? The Caribbean historically has never ordered vaccine in a block. The Caribbean has ordered as countries through the revolving fund, which access vaccines in block for the Americas through Pan American Health Organization. So I think it's, as Karen said, it's the same sort of entity that will be utilized for this vaccine. So you will see them like individuals as they are, but they all converge in one area where that it is being done as the Americas.
Thank you. There's, I have another question which says, was the vaccine tested in persons with comorbidities? I don't know if any of the presenters will be able to address this.
Yes, I can address that, Sandra.
Okay.
Yes, vaccine was tested in adults with comorbidities. The age groups were generally over 18 years of age. Some went to 55, some went to a bit older, but yes, it was tested with persons with comorbidities.
Yeah.
Thank you very much. Another question said, I would like to know, a patient who has recovered from COVID-19, would they be considered a candidate for the vaccine?
That is a very good question, and one that is being debated, and the regulatory bodies are looking at the vaccine data to make a decision on what will be recommended for persons who have already had COVID. That it will be a recommendation that comes out from WHO SAGE when a vaccine is approved.
Thank you.
All right. And can I make another comment? Remember also that those that you know who were vaccinated, who had the disease, would have been persons who were hospitalized or who were diagnosed. Remember that you will also have a population that would have been exposed and they would have had the disease, but if they were asymptomatic, etc., they would not have come to the health sector. So some of that, so as what Karen said, that decisions going to have to be made, but at the same time, you know that some of that will occur because you know persons, as with any vaccine preventable disease, where you do not have documented fact that that person had the disease, so you have no evidence, the person would be normally vaccinated. So I can't just go up and say, I have had COVID-19 infection, and so I don't need the vaccination. It means that you would have had to have it documented.
Thank you so much, Dr. Irons and Dr. Broom. These are some excellent questions. I have a couple others here. This one said, has PAHO done any analysis of the potential impact of the politicalization discussion on the uptake? That's one. And there's another question in which is being asked, if we, can you say what is the current state of the Cuba vaccine trial? I don't know which one of you, Dr. Irons, Dr. Broom, would want to take those questions.
I will start, Sandra. One, I cannot, let me take the second one first. I cannot tell you about the Cuba trial. That is something that I can research and get back to you. I don't have any information on that at this time. The other question about, and it's gone out of my head. What was the first question, Sandra?
Has PAHO done any analysis?
Oh yes. Oh yes,
yeah.
yes. So yes, we have actually done there was quite a large survey done about the attitudes of persons to COVID-19 vaccine, and it did have a section on persons political, how their acceptance was affected by their political persuasions. So that has been done, and it did show that there was a difference, that there was a significant difference with persons of, especially in the US, with persons from one party to another who identified with one party or another in terms of their acceptance of the vaccine. So this sort of survey and research, yes, has been done, and we continue to do surveys, especially among our priority groups. And we're preparing surveys right now for healthcare workers and persons in the older age group, as we know that they are priority cohorts to receive the vaccine.
Do you have anything else to add, Dr. Iron, or else I could move to the other question?
No, I think you can move. It was adequately answered. Thank you.
Sure. The other question says, could you comment further on the safety of the mRNA vaccines? Given the short timeline for vaccine testing, is there any concern about long-term negative effects, particularly using this new technology?
Dr.
Karen, would you like me to?
Yes, you go ahead.
Okay. As was stated in the presentation, and both Karen and myself, the mRNA technology has been utilized for a long time. It has been utilized in the aspect of treatment for many cancers, where they identify the cancer cells for destruction, etc. Well, and as we stated before, that there has been research started from some time ago on the coronaviruses, and in 2000, with emphasis and acceleration in 2005 and in 2012. And so, since there was already a platform, then this for COVID-19, they already had a jump start. Put it like this. So it's not just short. And it was not a short time period. And then the other aspect of it, that they did the trials. Normally, you know, phase 3 trials in the development of vaccine would have been like 10,000 persons. And you will notice that they did 43,000 and over 30,000. So and these were groups all over the world. And so I appreciate the question very well, and I think these questions be asked, but I am not particularly concerned about it, because I think the safety and efficacy of the vaccine has been shown from the data that has been presented. Yes, there were side effects of every vaccines that you see. There are side effects where you have redness, etc., side effects as it pertains to the site of vaccination. There were also side effects as it pertained to malaise and fatigue, etc., but there weren't severe side effects. And then the system that's in place for monitoring adverse events and also the regulatory post-market surveillance that is being done is extensive. All right. And we have to remember that every drug we take have benefits and they have side effects. And so we have to balance the public good against whatever adverse effects. And the adverse effects that are available right now and that we have seen from the data are minimal. And that's why I made the comment that I will take the vaccine, because I have looked at it. I have worked in vaccination for many, many, many years, over 20 years. So I have been forefront nationally and at the Caribbean level, where we did mass vaccination of adults for disease elimination. And I'm the first one would have put up a red flag if I were worried. And I don't have a red flag up. Thank you.
Thank you so much. I think that's all the questions that we have posted.
Ask Karen if she has any comments, please. Karen?
Sorry, Karen?
No, that was a well thought out and articulated answer. No other responses from me.
Thank you. So as I was saying, that's the end of all the questions that we have posted. These were some very excellent questions, which I think address some of the concerns that individuals have regarding this the COVID vaccine. We did a poll earlier at the start of the webinar, and also at the end of the presentation, because we wanted to actually see the impact of the presentation based on how people will respond to these questions. So is this the first poll, Shanti? This is the
second poll. I can show the first one. Should I go to the first?
Yes, we could look at the first one, and then we could see what if there are any changes as a result of the presentation.
Okay, 1 second for me.
But we see that for the second poll, the question says, do you plan to take the COVID-19 vaccine when it becomes available? Y- 48% says yes, and 43% said that they'll be unsure. So we have like a half and a half. People are split. With half will say yes, I will, and the other half says, well, I'm still not certain. So I think we will have to do some additional discussion for those that are still unsure. And when we look at the first poll that was done prior to the presentation, it was also a split, um, half and a half. Well, it's exact. So we had just a few additional that decided that they would take the vaccine following the presentation. So Dr. Broom, you can see where the planning will need to happen going forward as the Caribbean look forward to roll out, and hopefully in the near future, this vaccine. Any last comments from yourself and from Dr. Broom and Dr. Ayers based on what the poll is showing?
Thank you, Sandra. I just want to say that it is important that we all seek information and make sure that we are well informed to make our decisions. As we go forward, there will be more information out, and there will also be communication within the Caribbean about the safety and the efficacy of the vaccines, and to help promote vaccination and encourage people to take the vaccine. We are also, as I said, going down to the ground to do our surveys to find out what are persons' concerns so that we can adequately address these concerns and make sure that we reduce the anxiety that persons may be feeling about the vaccine. It is something new, and it is normal for persons to be unsure and to have a bit of anxiety. But it is also our role to assist and to guide and make sure that persons have all of the accurate data and information at their fingertips so that they can make a well-informed decision. And I want to say thank you very much to the organizers of this meeting in allowing myself to be here representing PAHO and to be able to make presentations and help inform and answer questions and clear up any gaps that persons may have had. Thank you very much.
All right, I am very encouraged by the result, and I'm very optimistic because it's nice to know that I did not see 40% no. I saw 40 onshore. And so when you're onshore, you can easily be moved. When I said easily, it means that you need additional information, as Karen said. And so we know that when the appropriate information is given and they read it for themselves and they look at all the different aspects, they will realize that it's a good vaccine. And so I'm quite optimistic. And I am happy that we have this information. As I said before, it has been my pleasure, and it continues to be my pleasure. And I really want to thank the organizers for inviting me to be a part and to be involved in this webinar. Thank you very much, and have a blessed afternoon. Thank you.
Dr. Broom, looking at the 45% that is onshore, can you inform participants where they could access additional information if they would want to read up more, or to be able to share with families and friends?
Sure, Sandra. Information is always on our PAHO or WHO websites, including all of our guidance documents are there. In terms of when we approve a vaccine, then the information on the vaccine will be there as well. So once you follow the WHO or PAHO websites, the information will be there, and it's posted, and we update quite regularly.
Thank you very much. And I would ask everyone to just join me in once again thanking our two presenters for the excellent presentations that they have just completed on the access to the COVID-19 vaccine, and also highlighting the COVAX mechanism. We really do appreciate the information that was shared, and I'm sure this is the first step towards sensitizing and informing the Caribbean populace of this new, well, not of the vaccine, but trying to get people to actually get to the stage where they will accept the vaccine. We have come, so thanks to the presenter again. I want to thank all the participants for actually joining us for the last series of this webinar, which is focusing on COVID-19 vaccine. We have come to the end of the webinar for today. Before I turn over to Dr. Singh, who will be wrapping up, I want to personally thank you, and also on behalf of PAHO, for your ongoing participation and support in the webinars that we at PAHO have been at PAHO and PANCAP. We have been jointly planning and implementing. And also, I want to actually thank PANCAP and the team at PANCAP for their ongoing support and collaboration, and for working closely with us in getting information on COVID-19 to the Caribbean population. So thank you very much to Dr. Rosman. Thank you very much, Shanti. Thank you very much, Timothy. And thank you very much, Anita. I think this has been an extremely wonderful year with the collaboration. As I mentioned earlier, ensure that accurate and timely information reach the Caribbean populace. Thank you. And Shanti, I turn over to you.
Thank you very much, Sandra. This has been a webinar, a PANCAP webinar collaboration with PAHO, and I want to endorse everything that Sandra has said in terms of thanking our presenters. I think they have been two really comprehensive and very timely presentation. Thank you both for taking us through some of the very basics of immunization, from the definition, the importance of herd immunity and its role in protecting the general population, but really grounding a lot of what we talked about this afternoon on the successes of vaccination programs within the Caribbean region, and highlighting some of the successes that we have seen in the Caribbean that we need to build on for this COVAX, for the COVID-19 vaccine. Importantly, of course, is the role of government and the collaboration with technical partners, service providers, and the people themselves, the community that will need the vaccines. Thank you for sharing and bringing us up to date on the different modalities within the COVAX facility for gaining access to the vaccines, but really highlighting the importance of having national structures established so that once the vaccines become available in country, that there will be the mechanisms for rolling out a very comprehensive vaccination program. I think, like Sandra, some key takeaway messages, we had those highlighted on the last slide of the presentation. But like Sandra, I think a couple have jumped out of me, and I think one of the big ones that I have made a note in all caps is trust. And so there has to be trust. And I too am encouraged with the polls, 45% unsure. I think, you know, we have the necessary information. We continue to learn more about the vaccines, that we can certainly move more people from unsure into yes. But I think being able to address every concern that you may have in terms of, or every doubt, as Dr. Aaron says, irrespective of how trivial they may be, is really very important in increasing vaccine acceptance. And so again, I want to thank our presenters for sharing with us this afternoon. This really concludes a two-part webinar series on the COVID-19 vaccine, a PANCAP two-part webinar series in collaboration with PAHO. And so thanks again to Dr. Irons and Dr. Broom for spending your time and for sharing with us this afternoon. This webinar also brings us to the end of our technical webinars for this year. It has been a very interesting, challenging year for us. And so we would like to, on behalf of PANCAP and PAHO, and on behalf of my director, Dr. Rosamond Adams, thank you all for participating in the webinar over the last 12 months. It has been a pleasure and a privilege to really provide to you evidence-based and timely intervention as we worked our way through this epidemic from the beginning of this pandemic from the very beginning of the year. I wish you all the very best for the holidays to you and your families, and that you celebrate safely. We are still in the pandemic, vaccines are here, but we still have a far way to go. Thank you all. Please stay engaged with PANCAP, stay engaged with the partnership, and we will all see you again next year as we continue our technical webinars and continue to provide you with information, with knowledge that will enhance your work in the new year. Thank you again on behalf of PANCAP, my director, Dr. Rosamond Adams, and on behalf of the Pan American Health Organization. Have a good day, everyone.